myself off the floor.
Welcome to Difficult Conversations About Beauty. My name is Anita East, and I'm a nurse practitioner specialising in aesthetic, skin, and integrative medicine. I'm so delighted to have you here. But can I get you to do me a favour and just look around you out there? It can be super confusing trying to work out what's true and what's not in this world of beauty and health. So during each episode, we seek to dispel the myths, find the truth, and empower one another with ready-to-implement advice that will make your life so much better than before you started listening. Just as a reminder, the podcast is not intended as a substitute for the medical advice of legitimate healthcare practitioners. The listener should regularly consult a healthcare practitioner in matters relating to their health, particularly with respect to any symptoms that may require diagnosis or medical attention. Thank you so much for listening and enjoy. Well, oh my goodness, Ryan, I am so excited to have you here today because when I first met you, it was on the dance floor. And I know that sounds really kind of, a bit silly, but it's true. I met you on the dance floor at NSS 2023. And since then, I think you're absolutely incredible. But I just want you to introduce yourself and tell us a little bit about Dr. Ryan Shannan.
I'm a GP. I'm a cosmetic doctor. I've been a GP or a fellowed in 2017. I started my aesthetic journey about 3 years ago.
Mm-hmm.
And so by all accounts, I'm kind of still a baby injector.
You're a baby!
I think I've grown pretty well, and by all regards, and I'm really passionate about it. It's part of my or integrated well into my personality. So I tend to be a perfectionistic. I like things that are aesthetic in all domains of my life. So it just was a perfect fit for me.
I think one of the first things I noticed about you, and you mentioned about your perfectionism, but certainly in terms of your style and just the aura that you have about you, not only in the way you look and the way you dress, but also in the way you present yourself. And I think that's really interesting to see that in someone medical who's come from being a GP into the world of aesthetics. Ryan, what actually made you change from GP land into aesthetics? Like what was your instigating factor? Was there an event that happened or something that happened and you went, oh gosh, this is really interesting? Because again, you're so aesthetic yourself that it's not surprising that this is where you've ended up.
So for most of us in doctors or GPs in the doing general practice does tend to be overall believe it or not, is a very stressful thing to do, because it's at the end of the day it's you're doing one-on-one with the patient. And the way Medicare works or the health system works is you need to be quote unquote efficient or efficient. So for you to generate any meaningful or an income that can sustain your practice, or so you need to see a good number and utilize the hundreds, if not thousands of MBS item numbers to generate an income that's an income, and also to keep things interesting for you and interesting for yourself. Aesthetic does simplify that for most of us in the sense that we don't necessarily depend on Medicare. And so for a lot of us, we like to diversify our portfolio and also have that kind of skill set that we can also bring into our general practice and for our patient. Because for a lot of us, we do skin cancer work. So a lot of that does tend to have an aesthetic element to it when you're planning a flap or a graft, and how that's gonna heal, and how you improve the healing prospect and outcome for your patients. So, and if you encounter complications, how or that are not necessarily aesthetically pleasing, how you can navigate around it. The hard thing is how to get into it and how to stand out in the crowd. So that's really the tricky part, and that's what a lot of us fail at, and a lot of us will just give up at some point.
You're doing skin cancer surgery as a GP rurally, I take it.
Yeah, so I know, rurally, so predominantly because I'm rural trained. I spent 4 years in a small country town called Echuca for 3 hours north of Melbourne. So I did that for 4 years. It was an interesting, time because you probably know, like an hour or 2 hours of Sydney, GPs do, or any city, like GPs do more, do a lot more.
Yes.
So I had colleagues that do GPs who do obstetric almost full time, and I mean minor and major surgeries. And a colleague of mine was doing colonoscopies, and a lot of them were doing neonatal and H high dependency units. And I was doing ward rounds and covering the hospital on weekends. So it was an interesting time to. And there's nothing called necessarily a specialist that you can call or refer to. So you really have to sort out everything yourself.
And then you found yourself in Sydney. And from what I understand, you work at the Manse. Is that correct, in Sydney?
Yeah, a year and a half exactly now. So I've started in the Manse a year and a half. I started so I was working in a skin cancer clinic in Sydney, and then I started introducing aesthetic into my GP work, and that worked out reasonably well. But at the end of the day, like, people don't want to go to their GP for their aesthetic needs necessarily.
Sure.
So I joined the Manse, and joined the Manse in March last year. So yeah, exactly. It's been a year and a half.
You suit the Manse. The Manse and you go well together.
Exactly. And so we align, both of us, in value and how we like to present and project ourselves into the industry and to our patients. I agree with you in a sense that in general terms, in the field, we do tend to be, sorry for the word, a little bit uptight and a little bit put ourselves in a small tiny box that we are afraid to break out of, because we get labeled unprofessional,
not serious, maybe.
Not serious or not graceful, or whatever the label is. It's kind of but anyhow, I'll talk about it. I'll talk about it later.
Yeah, I love that.
Because maybe at the last point, because it's one of the points that if I start talking about, I'll never shut up.
Oh, well, I mean, like I said, the first thing, it's funny because I had Agnes on my podcast a few weeks ago, and she again is someone who exudes this incredible sense of style, and with that comes this. For me, I look at you and I look at her and I look at people who have that gorgeous identity in terms of they know what they are, who they are, and they let themselves express that in the field of aesthetics, which at the end of the day, it's a form of medicine. It's medicine. We're dealing with drugs on the daily basis, but it's really lovely, I think, and really refreshing to see this ability for people's personalities to actually come out finally, so that we can see what makes everyone different. And we can see, patients can certainly make a choice and say, well, I love Ryan's personality, so I'm going to go and see him.
We have this tendency, like we do internally, although we don't say it, but it does manifest in our behavior and the way we dress and the way we convey ourselves to the universe. We do have an internal dialogue that actually worries how people perceive us and people think about us. We always say, oh, I don't care what people think or say about me, but if you observe the behavior, we do tend to care what people think, and that's something I bring up a lot around people, especially in the medical industry, because a lot of us can miss out on a lot of goodness in life and a lot of opportunities by boxing themselves in that corner in which they tend to wanna just disappear in the crowd and not stand out, and not stand out in a fear that and in a fear that they will be judged, or they will be noticed, or they will be a subject of talk or hate or conversation. Now there is so much freedom and so much uh, goodness that you can bring into your life, and fun that you can bring into your life and people and the life of people around you. If you can, uh, the word I would use, or I would describe how I like to convey myself, is to uh, be playful. Now it's a little bit, I like to describe myself or describe how I think about myself, the way I dress, the way I talk, the way I meet people, the way to be uh, uh, playful about it. If I'm gonna try, this shirt or this hat or this these shoes, I want to wear something that actually I find for myself that it's, as we said, like it's aesthetically pleasing. If I look at it, I feel and I say, okay, this actually looks good, and I feel good about it, and I can actually be playful about it. I can be, and with that comes a degree of it. You have to as a to be absolutely non-reactive. So there will be people uh, who are on the other spectrum that will look at you uh,
and
in
tut.
yeah, and like they're with the looks of unease, or
And it's so that we can feel comfortable ourselves, I think. People say things about other people so that they can remove themselves from that. But it's interesting because I think you have nailed how to find that joyful and playful thing in your life on the daily basis. And you're going, look, it doesn't actually matter if people who disagree with this, or if people who are haters turn their nose up, then actually what they should be doing is looking in the mirror themselves and going, well, why aren't I finding playfulness in my life? So have you had a problem with people judging and people negatively? Because I do nothing but when I see someone like you and when I'm in your presence is go, I just want more of it, not less of it, more of it.
Exactly. So the vast majority of people will be like you, that they will probably see a value from having an interaction with a person, with a lady like Agnes. They will, by nature, we are gravitated primitively to people who, like, Agnes, she's gorgeous, people who are good looking, and people who present, we primitively gravitate towards people who are like that. So um and I believe if I'm ever in a situation or in a place where I find people gravitate towards me, I like I like to believe that I should, and I always tend to share that value with them. So if I always smile at people, and the other word I usually also preach a lot, to be universally kind to everyone, meaning it doesn't matter if they're a male, female, if they're attractive, not attractive. If they smile, you smile back. You go to introduce yourself, and you have a conversation with them with it, and people appreciate that and remember you for that, because you have um, you have acknowledged them, and also gave them an opportunity to talk, and also to come into the if it was ever a circle where dancing or drinking, and you bring them into that circle, they appreciate it they appreciate you for that. Because a lot of
Absolutely.
people are a lot of people, you know, no matter if they're 15 or 20 or 40 or 50, people do have the tendency or predominantly to be very shy and inhibited.
Mm.
And as I said, it's sad that it will make them miss out on a lot of goodness into. And what we're doing here is a good example. Like
Mm.
I saw you at the dance floor, and we had we had a dance, and then I introduced myself, and I got your name, and then we continued talking the next day, and here we are. So
I
there's
know.
a lot, and we're good friends now. You know,
And it's
sadly,
interesting because that's exactly how I felt. And I was like, oh my gosh, this guy's an incredible dancer, which we need to get to. I need to know how you're such an incredible dancer. But you're also so loving and kind. And we don't remember what people remember is how other people make them feel. And so you made me feel like I was queen of the dance floor. You made me feel like I was fantastic. And then, like you said, you know, we continued chatting the next day. And then, you know, you made me feel like I was special. And if we can make other people feel like they're special, you know, if we look at someone and we imagine that they've got a sign saying, make me feel good, it can be something really small, like smiling at them, like you say, or, you know, saying, how are you, that kind of thing. And I think that really ties in with going into something like aesthetics, where we're not actually curing, you know, or treating disease. We're actually helping people feel better about themselves in how they look and so forth.
you know, on the uh, in a proper, you know, dancing school or dancing,
Mm-hmm.
you know, a very I'm a beginner. Like there was
Wow.
Kalia, one of the lovely girls I was dancing with at Aesthetic 23, and you know, I was dancing with everyone, and she was a professional dancer and also like a dancing teacher, and she gave me a mini tutorial or dancing lesson on the dance floor. So by all means, um, I'm a beginner, but how I like to think about it is um, if you it comes to the words that you said. If you it's all about how you make other people feel. If you dance, if you can be the best dancer and throw the best number on the dance floor, and everyone clapping for you, but you're doing it on your own, people will forget you the next day.
Mm-hmm.
People will not, because you know you're showing your skills, and people surround, you know, are amused with your skill set, and they're clapping. The whole dance floor is clapping for you. That's by all means, I'm not saying that's a bad thing. That's
Mm.
amazing. But the tendency for us as a human being, you'll be forgotten the next 10 minutes.
Yes.
But if you dance with someone, and even if you have a handful of moves and you have a basic rhythm, I like to think I do have a basic rhythm, but
Yes, you do.
most of my dancing friends don't. They think I suck. I suck really bad. But a handful of moves, like you don't
Yeah.
need to have a lot, and you focus on moves that uh, will actually make your dancing partner the center of attention, and also to make
Mm.
them feel good, make them feel good, you know, just a handful of moves that will um, uh, bring them joy.
Mm.
That's really enough.
Yeah, totally
For
agree.
that's not, I wouldn't say enough, but that's a lot that
Mm.
you can, you know, to bring into the dance floor, into you know, these kind of social events, and
Mm.
people remember
Absolutely.
you because it's as you said, how you made them feel. You are giving them value. You are
Mm.
you know, giving them new experiences, and um like I heard someone like in another conference, she was telling her friends, go dance with Ryan. I swear it's better than sex. Go.
Well, you
That's
wait
what
until the next conference. You'll have a lineup of women wanting to dance with you. You'll have to, I don't know what we'll do. I mean, you know, gosh, will we have to have a number and you pick and choose? We'll have to do a little audition for you.
No, and I promise I'll be a lot better by then, because I'm actually taking a proper dancing lessons.
Oh, wow. Well, I can't wait to be led by
just
you again.
uh, yeah, fingers crossed. I'll be better this time. But,
Excellent.
it's not fake it till you make it. It's actually fake it till you become it. If you're not a great dancer, just get the basic rhythms, have a few moves, do it with a big smile on your face.
Yes.
By all chance, be non-reactive. If you ever screw up a move, or you flip and you fall on your ass, and just laugh and smile, and it's like, and stand up and joke about it.
Yeah.
It's just but just by doing this kind of, I would say, like this kind of non-reactive moves, you will exert a huge amount of confidence, and people will assume that you're actually will assume that you're a good dancer. They just will. If you do whatever you do with a bit of confidence and non-reactivity, and be fun about it, people will assume subconsciously you're good. You know about the halo effect, right? To being aesthetically pleasing. So primitively, as human beings, we do gravitate towards people who are good looking or present well, but we also subconsciously assume that they are good at what they're doing, and sadly that will be across the board. It's uncanny. Like, you would think people would not care what their GP or primary health physician looks like, but subconsciously they do. We assume that people who are good looking, that they are good at what they're doing. The only thing that's applicable in some of these scenarios, is the halo effect. We do gravitate and think that towards people who are good and good looking, and if we ever think that looks do not matter, or the way you dress does not matter in your field, you're absolutely wrong. You're just gonna need to learn it the hard way, that all of these doesn't matter.
Yeah, and I think with that, you know, people have something that's unique about them in the way they look, and it's important, I think, from an aesthetic perspective, that we as practitioners look to in making sure that their lead actor remains as their lead actor, because that's my messaging, is all about, you've got one unique facial feature, that's your lead actor. The other facial features are your supporting actor, and they need to stay in that supporting role to always make sure that your lead actor is the thing that has the spotlight on it. So, and I think that patients look to us, especially if their practitioner looks aesthetically pleasing and says, oh, well, they understand, because look at them, they look good, they understand, therefore I'm going to put my trust in that person to be able to help me reach my potential in terms of the way I look. And I think as well, in terms of the way we dress as well, that can be a tricky one, because as people get older, especially women get older, they change physically, their body changes, and what they used to get away with wearing no longer suits them. And that's hard, you know, that's really hard. I speak from experience.
Yeah, and I see you rolling your eyes when you say when women get older, you roll your eyes up. No, you're not old by all means. Like,
but it's like, you know, the kind of clothing that I used to wear and get away with, I couldn't do that now, you know, and it's hard to accept that. It really is. But that's a whole other thing.
I want to say, like, all what I'm saying is, like, or I'm opening up to you, you know, in this interview, is things that like came to me over time and from life experiences. It's and I'm saying this not, you know, quote unquote as a brag. It's just something I want to convey, and for my colleagues, who's seeing this, is to maybe think about things that we were saying here, and maybe say, maybe maybe I could loosen up a bit. So we lose a lot of fun and playfulness in our lives. And do you know Hans Zimmer?
Yeah.
Yeah, so I love him to death, and he has a and I went to his concert this year for my birthday, in Nice. He has a documentary, and at the end of it, um, he said, and he's in his 60s, and
Mm,
he's like a rock star on in his concerts, and he uses the same thing. He uses um the word playfulness.
mm,
And
mm.
he, at the end of the documentary, he said there is so little joy you can get out of life if you're not being playful about it. And that resonates with me to a large extent. So if I ever want to send the message out there to people, uh, be playful about who you are and how you carry yourself, and you'll find yourself having a lot of more fun, and
Mm.
you'll have give and people around you will have more fun around you, and you'll have better life experiences.
So maybe
Now,
just don't take yourself so seriously.
yeah, it's
Yeah.
not the way I describe it. A lot. I see a lot of my colleagues in and out of their rooms, and I look at him and I say, dude, like, chill. You're looking like you're either coming from a colonoscopy or going for a colonoscopy. Like, you just relax. Just relax, breathe, smile more, smile for no reason whatsoever.
Yeah,
That's a good place to start.
I
Now,
love that.
on to the serious.
So,
Serious.
okay, so in terms of ultrasound, I'm a newbie with ultrasound. I only started using ultrasound in my clinic this year, and that was because I had one of those adverse events that none of us want to get. And I had a vascular occlusion in November of last year, my first one. And I didn't have ultrasound, and no one around me, no clinicians around me in Brisbane had an ultrasound who could help me. So I resolved it with the good old fashioned way of just basically hitting and hoping and just putting high lays absolutely everywhere. You saw me present my case at NSS. So, but I introduced ultrasound. I had the training. I've got the Vino. I had the training with Stuart, and I brought it into the clinic. But you are I think you're an expert in ultrasound, and I want to know how you started and why you started using ultrasound, and if you've got any interesting cases where ultrasound has helped.
First, I want to thank you. Like, in this industry where people, for the most part, the tendency is, hey, look at the great work I'm doing. Look at how great I am. Look at my amazing results. And you presented the opposite way, and you've been, very humble, and also you presented in front of one of them, a high.
I
Uh-huh.
know.
Like
I
one of
almost
someone,
died.
yeah, like I forgot her name, a lady from the medical board. Yeah,
Yes,
yeah,
from from
from the
AHPRA,
from AHPRA.
MBA.
So I was like, that's really brave. But he presented that case in a very humbling way, and also in a very uh, uh, you know uh, eye-opening educational way as well, because it's a lot of what really gets on my nerves sometimes when people say, oh, I don't need to do this, I never had an occlusion. And the thing is, no one had anything till they had it.
Yes.
No one had an occlusion till they had it. No one had a case of blindness till they had it. No one woke up one morning and say, I'm gonna block someone ophthalmic artery today
Mm,
at 2:30 p.m. No one
mm,
ever woke up saying that. It just, if it happens, it happens. You
mm.
need the mantra is, I never had it. It should be wiped
Yeah.
out of our
Mm,
consciousness. It's No one had anything till they had it. So we
mm,
need to be prepared, and treat every case as a potential one. Like,
mm,
do everything you can do during your injection, and if it and before, during your injection, for it not to happen. But if it happens, you need to have something to, some mechanisms in place to resolve it. So again, thank you for presenting that case. It was actually very educational, even like I learned a lot myself from it. Thank you.
Yeah, great.
So it was a nasolabial fold, I remember, right?
Yes, it was.
Yes,
It was, and it was a common injection technique in terms of needle onto bone, onto periosteum at piriform fossa. And thankfully, all I can say is thankfully it was 0.1 of a mil of stylage small that I used that actually created the VO. So yeah.
Interesting. Stillage S you used on the periosteum?
Yeah, because it was and it's always the way, I don't know about you, Ryan, but when it's like the last thing you do in a treatment, you think, I've got a little bit left. I said, I've got a little bit left. I'll just, because she was she's 33, so she's only young. And I thought, I'll just use this here. But it really, in essence, I should have said, I've got a little bit left and it's going in the bin.
Yes, exactly. Yeah. No, actually, that was another exactly the same. So she had another vascular occlusion I dealt with probably around April this year.
Mm-hmm.
April this year, I think. Yeah, it was a vascular occlusion in the nasolabial fold. She was a lovely girl who had her lips treated, and the injector said, "I have a tiny bit left. Let's do it in a cannula in the nasolabial fold." And that's and she had I would say like a major occlusion. It took I think an hour or two, an hour and a half to reverse, and then another hour of scanning at the end of the day to make sure that the occlusion resolved. It took 2 hours of work to reverse. Anyhow, back to the point. So I got as we started, I'm a GP, but when I started in aesthetics, I had this mindset that we need that from the get-go that I need to learn or introduce ultrasound into my practice. In aesthetics, it's still shocking to me the amount of uncertainty we live with and deal with in aesthetics, except this degree of vagueness and uncertainty in other clinical applications. So for us, put it in the midline in the nose, and in 91% of cases they don't have a crossing there. But what about the other 9%? Well, shrug your shoulders and fingers crossed, and it'll be good. We don't accept that in other fields of medicine. Why do we need to accept it or tolerate it in aesthetics? So the moment I joined it, when I sat with Naomi, we were having lunch when I was being introduced to the MANS in March last year, and one of the first questions I asked her, "Do you guys have an ultrasound machine in the clinic?" And she said, "Yes, we do." And I'm like, "Excellent, excellent, excellent." Now, the first week I started at the MANS, I grabbed the ultrasound machine, and the first thing I started scanning was filler. And at that point of time, till this day, there is not a lot of good clinical resources to teach us how to upskill or how to acquire the skill set to use ultrasound efficiently and effectively. Till this day, there are probably not a lot, or like not and the tendency there will be a lot of presentations that you're gonna see in conferences from in the past and ongoing that will be like, look at this. This is the black thing. That's filler. This is the muscle. This is the filler doing this on that blood vessel. For the person to be able to get that view of that filler and to get that view of the blood vessels in the same view, it requires a lot of skill set and a lot of experience to get them both in the same view, and for them to be to get an image that you can actually freeze and put on your Instagram or put on any other platform. And that you only can acquire that at this point of time through countless hours of scanning. So I appreciate when you're saying that you couldn't find someone that has an ultrasound. Now, there is the thing about having an ultrasound, and there is another thing, which is knowing what to do with it and what to do with it, and for you to use it in a, let's say you have the experience that you're able to get a nice view, you're able to visualize what you need to visualize, you have the structure interrogated, you know what you're looking at, but how can you take what you see on the ultrasound machine and translate that into a clinical decision making? Now, there is, between these two, there is uh, uh, a huge gap of knowledge and evidence that is not quite there yet. So the best thing we can do, and a lot of us in the field are doing, we're hypothesizing how we interpret that filler in that position, in that proximity to that structure, and how I dealt with it personally, and I put it out on a presentation. Now, that's what the community is doing pretty much with the ultrasound. And for the most part, that's the best we can do at this point of time. But so there is a huge gap, but at this, like in, but the good thing about it, it is a new science. It is a growing field.
There's a lot of interest in it.
There's a lot of interest, and there is a lot of dropout as well. So a lot of people will buy an ultrasound machine, and then like 2 or 3 months they bring it to work with them every day for like 3-4 weeks, and then they kind of shrug their shoulders and say, oh, this is too much, and then they leave it at home afterwards. It's not a defibrillator. You can't really expect that you're gonna have an occlusion and then you're gonna dust your ultrasound machine off and you're gonna plug it in, and then you're gonna be able to resolve or know what you're seeing. It doesn't work that way.
And I'm guilty of that as well, in that I've had, I had the training with Stuart and Lisa Hackett at the start of the year. And then I was all excited about using it, and I used it a little bit, but then I didn't have time to integrate it into my appointments. And so I kind of like left it for, I'll use it if and when I'm uncertain about placement in this particular patient, or if I'm looking at, something that's already there. If there's existing dermal filler and I want to have a look at it. So interestingly, in the last 2 weeks, I've used it twice on patients to dissolve filler that they've had previously. One lady had she had it done, I think she said it was about a year ago. She had filler placed in her forehead. And since then, she's been really heavy because obviously the weight, she's actually unable to use her frontalis muscle at all anymore because it's so heavy. It's created this heaviness. And I said, oh my gosh, this is exciting. I can use my ultrasound, because I hate this. I hate it when people say this, but she wasn't treated at our clinic. So I don't have any of the notes or anything like that. I don't know anything about in terms of what she actually had in there, but I used the ultrasound to see. And I could see that the dermal filler was actually placed pretty much nicely embedded into her frontalis muscle. And it was making it heavy. So, and you could see that. So I used...
in the frontalis, you mean, or under the frontalis?
Well, in and under. So they'd obviously,
So it was done with a needle.
She couldn't remember. I don't think she knew, because she was numb, obviously, from the local anesthetic that was in the dermal filler. She had no idea what was done. She just knew that she'd had dermal filler in her forehead, and so I dissolved it. And it was so satisfying, even though I didn't dissolve it with the ultrasound on, but I circled where the dermal filler was, and then I dissolved it after that. And immediately, what was interesting, even though she was numb, obviously, from the dilution of my Hyalase, and I had local anesthetic in it, she was actually able to lift her eyebrows, and she was able to straight away say, I feel a lot less heavy. And we had video of her doing a frown and raising her eyebrows, and she could lift her eyebrows so much more without the weight of the dermal filler in her forehead.
Now that's a good example, but if it makes you feel any better, I almost never inject high layers directly under ultrasound guidance unless it's a very critical place to do so, like post-septal filler, and also if I'm gonna do high layers into the mid cheek where it's quite vascular. I don't want to necessarily give someone a bad bruise, so I do tend to do that with the under Doppler. I use ultrasound pretty much every day. But there is a lot of the biggest problem I think with ultrasound, and it's not just the steep learning curve, it's also the logistics of it. So even if you're a guru with ultrasound, by the time you turn on your ultrasound machine, you put the patient details, you optimize your view, that's like 5 minutes, and you're getting you're getting to have a look. So even the simplest things which are temples to get a proper view, that's the 10 minutes of your appointments. And on top of that, you might see things that you would or you see a deep arteries on the bone, so you'll say, okay, I'm going to do this technique or that technique instead. And so your appointment would have probably expanded from being 15 minutes to a 40 minutes appointment. Some people are being just honest with me. They say, in the amount of time I'm this 15 or 20 minutes I'm scanning someone, I can do a couple, 1 or 2 talks on another couple of patients and make an easy $1,000. So why am I like it? And couple that with that mentality of I never had an occlusion before. So so,
it's not going to happen to me. Like you said, it won't happen until it's happened. So yeah, I think that's interesting. And I think maybe the more of us who present cases, that things can happen to everyone and anyone, and the use of ultrasound, certainly in the case with my occlusion, I firmly believe that if I had an ultrasound machine, or I had access to an ultrasound machine, I would have been able to reverse that a lot sooner and with a lot less trauma in terms of needle trauma to my patient, which would have been obviously fantastic. But yeah, I think that's another stigma that we all have to get over, and that's okay. We're getting there, and people like yourself and Andrew Clark are chipping away at us, which is wonderful. But I also wanted to ask you, did you have like a little announcement or something? Was there something that you wanted to?
Well, since you brought, hopefully me and Andrew were talking about, doing some sort of collaboration for the next NSS. Hopefully we'll present that. Hopefully, fingers crossed. And the committee on the NSS, they're really keen on bringing ultrasound more and more into the frontier of aesthetics. So hopefully there will be a degree of collaboration between us to present something. And I'm keen to do something in the periorbital area, managing complications, or ultrasound, utilizing ultrasound and managing complications in the periorbital area. And I'm in talk with Andrew about it, and also I've been talking with a couple of colleagues in the US who have published a few papers in this field. So
yeah, making it easier to understand is really beneficial for the audience, and also for patients to understand as well. So I think that's a really great idea for you and Andrew. And being part of the NSS scientific committee, I know I'm going to be saying, this has to go through. Right. So hurry up and submit your abstract so I can tick it.
Thank you. Fingers crossed. But it's still a move in the right direction, I guess. So
what is your favorite treatment to do, and what do you predict as being, Ryan, the treatment of the future in aesthetics? Tricky one, hey? This is your last question.
The best treatment I like to do is chin and jawline, like, and I mean, like, that's just standard dermal filler, and it's something I like. I like to like. I don't. I'm not saying I'm a guru. I do things that you know, amazing, or but it's just like there's so much artistic elements that you can bring into doing both. So these three areas, so the nose and the chin and the jawline, because these three areas, they're predominantly 3D structures when you treat them with derm, or even with standard dermal filler. So when you there's so much artistic elements that you can bring into them, and it just and it takes and I enjoy them immensely, but they take me like an hour to do properly, because it's not about shoving a needle and putting zero point 0.6 here and 0.6 there and zero point 0.4 there. It's not about, there is so much that you can so much that you can do to balance someone's face and and give them a flattering flattering results, but it can take a fair bit of time, and it takes me a long time, but the results is something that people cannot go back from. Once they have it, they just love it, and all of us can do, including myself, to do better jobs with noses and also chins and jawline for men and women. If that could be it could be like a 1 mil, it could be 7 mils. Everyone's face is different, but once it's done with attention and care and an open aesthetic eye that's generous with time and attention, it's just amazing thing.
Wow. I love that. Oh, Brian, I have loved talking to you today. It feels like we've just caught up over a delicious cocktail, which will be lovely, and we'll do that next time we see each other. But thank you so much for your time. I've loved chatting with you.
And I loved it too. Like it's, and I look forward to seeing you again on or off the dance floor.
Absolutely.
I love that cocktail idea.
Me too. Well, thank you for coming on Difficult Conversations About Beauty, and I know that my audience will absolutely adore you. Thank you for listening. If you have enjoyed this episode, please share. Remember to give it 5 stars and write me a kind review. Remember, kindness always comes back to us. All discussed links will be in our show notes. And until next time, may you revel in your beautiful and unique faces, both today and always.